Hi, everybody. We are going to start, and I am going to continue on where we left off and then supplement it a little bit to finish up skin. So, this is, you might recall, this is where we started. Now, I'll scroll through that very quickly and take you kind of where we ended up, which is here chickenpox and shingles. So, and there's not a lot left in this that are there. And so I think I'll just get through it as we have here. So we kind of left at the start of the shingles portion, which is also known as herpes zoster. So we'll begin with that. So we had done this. We talked about the chicken pox, and you can see it's by no means innocent, but it's typically very rare. As long as people are able to uh, basically uh, rest for a period of time, it's very rare to see these kinds of complications, and we do obviously we don't see it around here very much at all whatsoever, which leads us to something we see constantly. And if you and I've seen statistics as much as 1/3 of us are going to get the shingles during our lifetime, because effectively we've all been exposed in one way or another, as you saw by earlier. It's just so it spreads so easily that everybody effectively, whether it impacts them or not, effectively carries this. So if you've been immunized for it, if you've had it, or if you've had it without knowing it whatsoever, it doesn't matter. You've now carried that virus with you. And so what happens, and again, it's when they talk about an asymmetrical distribution, it follows the course of a spinal sensory nerve. The herpes virus harbors in the dorsal root ganglia and follows their course. So they're latent in the ganglia and they reemerge in a totally different appearance as plaques that are very angry looking. And there's so many different things, so many stressors, immunosuppression, aging, which causes a loss, any underlying conditions, and not the least of which are traumatic events in a lifetime that predispose you to this. And you can see it here. It comes out with it does not look the same. It's much flatter. They don't burst open. They're very angry and they're very painful. So they migrate down the nerve, and it doesn't necessarily mean that it has to be in your body, even though the torso is certainly the most common. It can be involve cranial and sacral areas as well. Particularly cranial areas are quite bizarre, because I've seen them in the eye, I've seen them in the scalp, and to the eye where somebody couldn't even do anything with it. And facially, very distorting. One of my colleagues here had it to the point where he missed 3 weeks because of the distortion in his face was just, it was almost frightening that was there. And a comparatively young man who was in his late 30s, early 40s when this happened. So crops tender, yeah, they're vesicles, but they're much flatter. To me, they don't look the same. It's very inflammatory, and it can last for a very long period of time. And I've said this many times. The hardest thing I've had to deal with clinically is people with shingles, and at the time, since we didn't have the availability of Valtrex or the other antivirals, which are very useful for this, okay, was dealing with pain medicine, because all you could do is treat them with some type of steroidal agent and strong pain meds. So you were looking with, narcotic analgesics, which are addictive in nature and really a problem. You can see some of the stuff that happens in the eye, etc. And I've seen all of these. So again, it's human herpes virus 3, the varicella virus that you're so familiar with. We had this already. It starts respiratorily, it disseminates all over. And what happens is the characteristics are such: cells fuse, they lyse wherever they are, and it leads to that, what you see in the chicken pox. But what happens, the latency is in the dorsal root ganglia, and it's effectively there for effectively forever. It doesn't have to come out, but it may come out. And yes, there is an immunization, as you'll see they describe here, called Zostavax. I don't believe I've had that, but it is certainly one that's in the recommendations for people as they get older, because typically it's people in their 60s they start recommending that. respiratory droplets, and fluid from active lesions. So if somebody has the shingles and there's any weeping of fluid, if somebody who has not had the chickenpox and was not immunized for it, they'll get chickenpox. So you can't pass the shingles, don't get passed, but the virus itself gets passed. Okay, so as you can see, they can acquire chickenpox from exposure to the fluid. It doesn't take very long. It's very contagious. It's just there. This 1995 was the day as I said, my kids all had it effectively through 1988, 89 is when they had it. Zostavax, this was the one that was and it's really just a variation of the chickenpox immunization, more geared to the zoster or shingles lesions. It's self-limiting. Don't scratch anything. Aciclovir, stay away from the aspirin. Usual reminders, and that covers that. Smallpox we can't talk about for completion because it's effectively it's not there. What happened? And so there's a disease that has been eradicated as of 1977. You see that statistic all the time. But what happened was right there, right after 9/11, we had this. People began to worry about biological terrorism. And so, again, there's very, very limited, and they do keep a stock of this immunization. They particularly keep it for the military, and to be sure, that's bioweapons development, which we do just as much as anybody else, I'm sure. This is part of the arsenal potentially, and it starts, if you want to say innocently enough, pharynx and throat spreads, macular, papular, vesicular, pustular, but they're much more angry looking and widespread, and lots of scars. That was something we used to see with people who recovered, is the scarring that was there, and even the immunization that was used. I can recall to this day my mom having a rather distinctive scar with the way they used to administer it back in whenever she got it. I don't even know when. My mom was born in 1918. So let's say sometime during the 20s or early 30s is probably about the time. It's called variola major. Okay. Virulent toxemia shock, intravascular coagulation. It's just horrible. It's the ultimate bioweapon. It's respiratorily spread, and it has a tremendously high fatality rate, comparatively speaking. High fever, rash, pain. Rash spreads quickly. Very much an emergency situation. All of these types of things, you can read through it. Very, very ill. That's there. There is something called variola minor. It is the variola virus. It's a pox virus. They call it an orthopox virus. As you can see, vaccinia, which is the cowpox virus that we talked about early on, first days of the course, with Edward Jenner, and monkeypox, which you're hearing now, and even though it probably won't be in any of these PowerPoints or sequences, has become, and it's not the only pox virus, molluscum contagiosum is in that category as well. And these are, as you can see, and they survive longer. When we tend to see monkeypox and molluscum contagiosum, we typically see them from sexual contact that is there. So it's sometimes it's frictional, sometimes it's fluids. As far as we know, they're more the spreadable nature, but we're not seeing fatalities or anything like that with this. So droplets on fomites, as you can see, it was endemic in the 70s. Last case, 1977. You can see what happened. It was almost a mandate to deal with it. Even after exposure, there was a vaccination, etc. And that's as much as I can tell you about it. I've never seen this. They talk about it. You can see it's Central and South America. Typically, leishmaniasis is something, it's cutaneous, and it's in the capillaries that are there. It's a zoonosis from sandflies. It's just not something that we have to deal with because they're located mostly in equatorial regions. It's about, if you're traveling to those areas, that's of interest. That's there. And so, and with a lot of these vector-borne diseases, it's about controlling the vector. So when we deal with things, as we'll look at later, with whether it's ticks, whether it's mosquitoes, if you can stay away from them or control them or limit your exposure to them, basically you don't get exposed to it. Anthrax, historically very important. We do not see it now. And yes, was the bioterror weapon in 2001 because it was an endospore. And you might recall me telling you that was in the laboratory was weaponized. I mean, they reduced the spore coat so it could pass through the barrier of your nose. Usually it cannot. The only time we used to see it was in the old days with wool sorters disease, where they worked around sheep a lot, shearing them without protection long before they knew about how this was spread or what it was, and developed a disease called anthrax. Bacillus anthracis and that family of bacilli, aerobic endospore forming gram positive rods, cuts and abrasion. Okay, this was the one that they were concerned about through the mail, naturally transmitted with hides of infected animals, which is where people got it. And you could certainly, it's not difficult, but as you can see, untreated, even in the cutaneous form, from little cuts on the skin, 20% of the cases. Okay, again, the vaccine is used to, in those that they feel might be at risk for some type of bioterrorism that are there. And it's about as much as you can see. So mostly it's the cutaneous form of anthrax, and the respiratory form is comparatively rare. And I think this is one of the last areas. These are dermatophytes. They're really an important, and collectively they're called ringworm because when they grow, they tend to form a circular pattern. And originally, it was thought that they were like little worms under the skin. It just has to do with the way that sort of the circular way they grow, and they're very interesting because we look at them in their shape. There's three genera of these, and collectively we call them tinea. Okay, derived from the erroneous belief that they were caused by worms. So, and these are surface infections. They're in the dermal and epidermal area. These are the problem with them is they predispose you because they're itchy and they break down the skin to bacterial infections, which are a lot more harmful. So this is a primary, and we worry about the secondary infection. Normally, we just see them in the stratum corneum and the derivative hair and nails. So that's where you see them, and where they predispose moist or oily areas. So hair, moist and oily, facial, moist and oily, moist in the bottom of the feet, famous athlete's foot, groin areas, basically crotch related itch and things like that, jock itch, we used to call it for athletes and things like that. And there's three basic genera that are part of it. It's not important to know. One's called trichophidin, epidermophycosum, and microsporum. For instance, this is microsporum canis because it was shaped like little canoes. So that's a lot of times how they named them that were there. And so they all have interesting names, and you can see it. Tinea capitis, Tinea barbae in the beard, corpus in the body, cruris, that's the groin or jock itch. That's so much moisture and humidity and perspiration. Tinea pedis, athlete's foot, jungle rot, etc., etc. And tinea inguinum, which is very difficult to treat. The nails just crumble and they turn yellow and they smell and yuck, like that. I treated it. I treated a ton of this stuff. So here are the three genera, as I said before, because they are able to gobble up the keratin, which is what those outer layers are made of. They don't go deeper. Indirectly is when the dermis gets involved with itching and scratching. That's there. Oops. We term them as superficial mycoses. Mycosis because of the fungal. And topical, sometimes oral agents are there. That's basically what you do. Uh, Cosmetic rather than disease causing would be a good one. Here's one I talked about before, that versicolor is a yeast called Malassezia. A lot of different species, they live on the skin, that Malassezia fur, high oil content, and it's a player in folliculitis, psoriasis, and seborrheic dermatitis, famously called dandruff. So certain people, that's really it's controllable, and that's where basically topical shampoos and lotions work so effectively. Okay, and you can see there everybody's got it. It's a question of whether it affects you or not. And then this is where they do the carryover into the eye, and yeah, it's the windshield of the eye, and blah 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 blah, and all the stuff that's there without going into eye anatomy. But again, there's a lot of tears, lysozyme, lactoferrin, which gobbles up iron, which bacteria utilize for reproduction. and all of those things. So it can come to, and again, when you're seeing this, the lacrimal gland and the lacrimal duct and sac kind of go across the eye that way, and as you blink, you sort of spread it. So it's an area that is, relatively speaking, free of most problems. When it's abraded, it's a little kids rubbing their eyes with dirty hands. Whereas we see more in adults where it carries over by way of the lacrimal duct from upper respiratory infections. And that's why I think it's more respiratory. Maybe in kids, I'd consider it skin, and in adults, I'd consider it respiratory. So it's when they call immune privilege. I mean, this is an immunological area that's mostly spared unless there's something that's damaged, would be the best way to express it. And so all of these are part of it. Mucus is not something you'd find in there, for instance, what they're talking about. So, and are there some microbes? Yes, now that we have more advantageous ways of studying them, that are there. And the big problem is with conjunctivitis, which can be either viral or bacterial. The viral is itchy, but not very productive, in the sense you don't get a lot of drainage that's thick and heavy. You just get a lot of like liquid. Trouble is, you're very much predisposed to bacterial infections, which are dangerous and last much longer. You get that thick stuff, and maybe some of you have had this in your eye with conjunctivitis as kids, and it's almost like you wake up in the morning, it's all crusted, and it's tough to almost pry your eye open, and it hurts. If you get on top of it early with antibiotic drops, I think it works very effectively. And the prevention is, my wife will be the first one to tell you, I'm a terrible eye rubber. I do it all the time. It's just a bad habit you have to drop. And so all of those types of things. Most of the discharge is much more, again, organized, milky, purulent, viral, much more clear and watery. It's kind of shut together, things like that. Pink eye, because the inflammation causes the blood vessels in the conjunctiva to be more widened or swollen, and off against the white of the sclera, we get pink. And so here you can see these are, I mean, neonatally, these are ones because these can lead to blindness. This is when gonorrhea was the reason why we use eye drops in the eye. Now, we used to use silver nitrate in the eyes, had like turned the skin black. We don't do that anymore. Now we use antibiotic drops, mandatory, all states. And chlamydia, perhaps more common today. Vertical transmission, serious eye damage, and herpetic infections are even worse in a lot of ways, because it's not nearly as easy to treat. And so you can see there's a whole confluence. But again, strep pyogenes and Haemophilus influenza are probably the most common. A bigger part, strep pneumonia and Haemophilus influenza. These are the ones that are, if they're there from prior and sexual activity and active, that's a problem. There's a lot of things that can do it. High and very, very contagious. Okay. As you can see, there's so many topical things that you can use that are there. I did not know that they were using Cipro now. I don't know if it covers everything, but anyway, if they've done studies, that's fine. And when it gets deeper, and it can lead to blindness and corneal destruction, reactivation of oral herpes travels to the ophthalmic rather than the mandibular or trigeminal branch. I've seen it go into the eye, where I've seen infections like this. As you can see, herpetic infections, leading infectious cause of blindness in the United States, usually from other factors. Diabetes, for instance, would be a factor. That would be part of it, and a variety of inherent eye problems, macular degeneration, etc. And you see, and it can transfer with HSV2 as well. So here you can see it. It's not good unless you can start to treat it right away. There's a particular amoebic. This is one you hear about in certain swimming in water that's not chlorinated or salted. So pond water and lake water. This is an inherent problem. And at least my recommendation would be to make sure that you shower and rinse that off as quickly as possible once you're done. And that's just summarizing it. So that's everything there. So, which leaves me with at least one other area that I did want to talk to you about. There's a few other things on the Nestor PowerPoint that's here, and then I'll show it to you, but perhaps more over here in this portion of the Nestor PowerPoint. So they moved it from skin to immunological diseases, but it's time to talk about it, and that's Lyme disease, the single most common vector-borne disease, pardon me, in the United States. Immense. 30,000 new cases a year, and there's probably more. There are so many ticks of this nature, and the particular tick that's most commonly associated is called the deer tick. There's another one called the wood tick. So in the deer tick, it is effectively the tick is what's called a biological vector. The tick feeds on an infected animal like a rabbit or a mouse or a dog in the wild, or deer for that. Typically it's a deer tick, not because the deer is infected, but more likely because the deer is, as you'll see, part of its life cycle. It's where effectively the tick goes to lay eggs and dies, and future generations are born. And the deer is the common white-tailed deer, which we have in a lot of abundance around this neck of the woods. So we knew historically that ticks cause problems. I can remember we were being taught we had lecturers come in when I was in school, in medical school, saying, hey, listen, we don't know what it was. We saw it in Korea. We saw it in Vietnam. They had what's called tick paralysis. So what happened is they would find somebody who had ticks on their body, typically got in their sleeping bag, whatever they were sleeping in, and all of a sudden they could barely move. We did not know then, but we know now there's probably some variation of Lyme disease or some other tick-borne illness. So it was named because of where it was discovered, and the bacteria that was identified, interestingly, is a spirochete. It's called a gram-negative microaerophilic spirochete. This one's a little bit easier to culture, okay, but not by any means easy. And it's and comparatively easy to treat if you identify it quickly. If you don't, you're in big trouble. And just like its companion microaerophilic gram-negative spirochete, Treponema pallidum, which leads to syphilis, it goes through a series of stages that are immunologic in nature. It's the immune response that does the damage in this particular case. Why they now classify diseases of the blood and lymphatic systems, because those are immunological systems that are there. So as you can see, it's for these stages, and this is similar to syphilis, and you'll see it was named after the doctor who discovered it, whose name was Willy Bergdorf, and he called it Borrelia burgdorferi. And the name is stuck. And we really didn't see it until it became better known as time went on. I have seen people with a number of cases. It doesn't just affect humans, it affects pets that are there. It's one of those things that they get tested for. The dog we had before we had Lincoln was named Ralph, and we brought him in one time to our vet because they were having for $25 we were going to test for heartworm and for Lyme, and we were worried about the heartworm, and we got a call when we were on vacation. Guess what? It was the Lyme. So he came in and we had to put him on antibiotics, which worked fine. So 3 stages, and they don't have to be asymptomatic. Famously, the name of this was called a target or a bullseye rash. It's called erythema migrans because the redness kind of migrates. And what happens is, this is probably where the bite was, and they typically are in upper arms, upper thighs. Again, ticks kind of burrow in areas that are a little bit warm and a little bit moist and not very exposed. And it begins to form. And it starts here, it gets inflamed, then it clears, and it gets inflamed, and it clears, etc. And it's very distinctive. My wife had a classic one like this. It started off all red, and then all of a sudden this started to form. It was in her thigh. We went to urgent care once I saw it because I said, this is Lyme disease, and didn't have to do any testing. The doctor who saw it said, that's Lyme disease. We're treating it. And fortunately, we identified it very, very, very early. I think this was the summer of the lockdown, as I recall. I think this was the summer of 20 when this occurred. So it's erythema migrans and then lymph node enlargement. I don't recall if she had that. And thankfully, she did not have a lot of this. She just didn't feel good. And it was warm and it was swollen. So we caught it very, very early. So 2 to 8 weeks. So it starts from and about X number of weeks. And this is one of the problems. The rash disappears, and then as your immune system responds, because as the rash disappears, the bacteria is in your bloodstream and you respond immunologically, and it affects certain systems like your heart, dizzy spells, fainting, paralysis, stiff neck, pain, blah, blah, blah. uh, bone joint. What I would see is people had difficulty moving. You felt like arthritis. They were pain every time they tried to move. And then if you haven't addressed it by then it becomes, and at least here you have time, but when you get to late persistent, after the start of the reaction, all that appear and slowly, it can be years and it can be permanent damage that's there. And a lot of things are associated. I saw a case that I didn't identify right away. The first week, I thought she was seeking pain medicine. But I did a bunch of tests because I don't want to dismiss anybody. And she came back a couple of weeks later worse. She went from being in pain but able to move in and around to being in a wheelchair, where she couldn't move at all. And then all of a sudden, the history came out where she took her kids. It was right. Lyme disease time is not deer hunting season. It's where they are seeking a blood meal. And you'll see with the lifestyle, it is what occurs when these typically late spring, late spring, summer, early fall, because it's before they complete that stage of their life cycle, which occurs during the winter times. And they have a 2-year life cycle that you will see. And when she started telling me that she used to hike around, they couldn't do much. She had 3 little kids, and they'd hike in the woods, and it came after that, and all of a sudden, ding, 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 bell went off in my head. Sent her to an infectious disease specialist, did the Lyme disease tests, voila, Lyme disease positive. Put her on antibiotics, had to be on them for about a year, as I recall. Here it is, Borrelia burgdorferi. Okay, spirochetes into the inflammatory, migrate circular fashion. That's why you get that characteristic rash. Flu-like systems, and typically we think the immunological response is why this comes from, even an autoimmune type response. So whatever antibodies are being provoked are attacking healthy tissue and cause, whether it's joints, heart, nervous system, etc. So you can see the size. Here's a paperclip. Here's how small that tick is. You can see where it's located. Areas that have an abundance of deer and a lot of ticks are in standing water. So when you have those streams and that don't run anymore, or they're all clogged up and marshy type of things, and we have plenty of that around here. So you can see some of these. I mean, it really predominates in this area of the country. Saying eastern state, the deer tick, it's got a great name. Ticks have wonderful names. Ixodes scapularis. As you can see, tremendously infected. If you get bit by a tick, assume that's there and get it looked at. Okay, and it's a 2-year cycle, and it's in this stage called the nymph stage, which you're going to see over here, where it happens. So the tick is born with the eggs. Okay, drops from host and lay uninfected eggs. So the host is typically the deer, and they drop, and then they open up, and these little larvae seek a blood meal. They're hungry, so it could be any kind of animal, rodents, etc. Then, after the first year, they change from the larval stage to the tick stage, and then once again, start to transmit. They can transmit it to a whole new set for this stage, or they can transmit it to us. Okay, and particularly and this is where they tend to go up into here, those areas, underarms, upper thighs, etc. Then at the end of that, as they're adults, then they're going to mate, and where they effectively they feed on an animal host and mate, and then the female dominant, the male dies, and the eggs are laid and they come up. But the deer is important in that life cycle. So you can see that the incidents where they're active, May to December, depending on the weather. They're the preferred hosts, or they mate there. So that's why it's so important to understand the life cycle. Antibiotics work early, much less so late. Okay. And the whole idea is acceptable for you. I don't know if it still is the best. It's called DEET. I don't know if it has some type of internal problems, but we don't have a vaccine for it, anything like that. And there's a nice summary statement of it. It's there. So I wanted to include that in this little discussion, and we're gradually coming to an end pretty quickly here. And I'll show you what's left. There's a few other little nuggets that are in that particular, and I put this is PowerPoint 25 from Nestor. It is on your list. So it's got plague in there if you're interested in taking a look at that and some other immunological based diseases that are there. So it's from this 25A. And then this was the remainder of the skin PowerPoint from Nestor that I just want to, most of it we have done, but there's a couple of little nuggets that are probably worth talking about in this. And I'll just scroll through it quickly. This is one of them. This is a rickettsial disease we didn't know, and it was named for this researcher, Howard Ricketts, at the University of Chicago. And he was studying, it was a tick-borne disease, just like this, but it turned out it wasn't a spirochete. He didn't know what it was, so he named it after himself. He called them rickettsii, little rod-shaped, but he didn't know they were bacteria. When I learned about them in the 70s, all we knew about, we didn't know how to categorize rickettsia. But then with the advent of molecular biology, we found out that they had the ribosomes and the all that type of stuff, the way you could identify and classify as a gram-negative bacteria. So now we know they're obligate intracellular parasites because we couldn't grow them then until we knew how to grow them. And we had advanced testings with PCR and things like that to be able to identify it. And they could transmit, and even eggs were often infected, not necessarily the ticks themselves. And it was very similar to another vector borne by lice called typhus. And when he was studying that, he ended up dying. And so Proazeki met the same fate also. So we have typhus was named Rickettsia prowazekii, and Rocky Mountain Spotted Fever, RMSF, Rickettsia. And interestingly enough, it's because it's tick-borne, it's much more common around here. Those ticks, the wood tick is a little more common when you get into marshy areas that are predominant. So in the Ozarks and in the Carolinas, that's where you begin to see a greater amount of those than you do out for whatever reason. You went out to the Rockies and named it for that. And this is just talk about the skin, and we did all that. A little bit about acne. Okay. And it's an inflammatory nature, acne vulgaris, because sebaceous glands enlarged into it. Now they used to be called Propionibacterium acnes. Now it's Cutibacterium acne, gram-positive rod, anaerobic when it gets trapped inside, and the sebum acts as source in its inflammatory response, and the abscess. They form these big pustules that can be really problem. We have it, not everybody's prone to it. There's heredity. Hygiene certainly plays a role, but I think it's more hereditary with regard to those things. And some people are predisposed, some are not. And, I was fortunate in not. And then these are the difference with the staphylococcal infections. They go through all this. And you can scroll through it if you're interested. And it gives you, we got just as much from the other. The spread, the treatment, MRSA, scalded skin, you can see here. The name of the toxin you should recall is called exfoliatin, for exfoliating toxin. And again, it's about 5% of the strains carry it that are there. And you can see how they go over a little bit more. This is a very good image of what impetigo looks like with this sort of gold-crusted plasma. And we talked about the distinction why the strep is more scary. Here's the Rocky Mountain Spotted Fever. It's a very dangerous disease because it's gram-negative. And when these gram-negative products, it's kind of like a gram-negative sepsis. The clue, and it starts usually on the extremities, are the petechiae. These little, where the blood vessels start to go, this flat pink rash, wrists and ankles, etc., and it begins to spread centrally. But because gram-negative, you only get the gram-negative infection. So there's the name, and you can see it. Lining is the small blood vessels where the problems are. You see the distribution is different. To tick, looks similar, but it's not. but you can see into these really moist, swampy areas that are there. The anthrax we talked about already, varicella, etc., rubiola, measles, German measles. This is a numbering system. I have to look up and remind myself what Duke's disease is. But this is based on commons in the early 1900s. You can see fifth disease and roseola, but measles, scarlet fever, and rubella first on the list. The same thing we saw before. The only other note, yeah, for this last one I should mention to you is this. Most of the time when we get down to diaper rash, way down here, is this. So this is Candida albicans. It's a comparatively normal microbe. It's about the moisture. And again, controlling the moisture is where they grow. And it is by no means a bad case. There was a case within the last 10 or 15 years of a baby who died from a secondary bacterial infection from diaper rash. The problem was that he or she were never treated like this. But it is not a gram stain. This is a standard micrograph. You could do any kind of a stain. You could use a gram stain, and it would show like that, without having to go to oil. So I think it's more. It's why moisture, moisture, moisture. The standard is now. For years we used talcum powder. Problem with talcum powder is it's irritant. Tiny granules can be a problem, so they went to cornstarch based powders. And really, you could just use commercial cornstarch or baby cornstarch, unscented if you want. Much more effective at moisture control and much safer. And I think, everybody, that's everything for this morning. So thanks very much, and I'll send it to you. Bye bye.